So good evening, everyone. I'm Doc MK. I'm one of the faculties and mentors in Top Notch. And for today, I am giving the opportunity to give you the summary lecture for physiology. So we're going to have, I think, around 90 minutes for the whole summary of the lecture and then around 30 minutes later for the quiz master. So my advice lang is, since nabasa na ideally yung handout, no, just relax, listen lang kayo, and then try to absorb as much as you can, and then you'll figure it out eventually later on. Okay, so let's start first. Let's start now. Oops, sorry. Okay, so let's start with cell and muscle physiology. So I inserted some questions here, pero you don't need to really answer them. Pero mas maganda if on your own you can answer them. Okay, so omeprazole is one of the drugs used in treating peptic ulcer disease. What type of transporter is the target of this drug? So what type of transporter daw? So if you recall, omeprazole in your internship, right, is a proton pump inhibitor, and it targets the HK ATPase pump. So it's ATPase pump. So basically, it's a primary active transport. Okay, yan. So before we proceed with the transport, which is a very high yield topic for your physiology, let's recall your cell membrane. Okay. So recall that your cell membrane has many proteins, little carbohydrates, and no water. So, Doc, wala siyang water, pero bakit siya fluid, no? So take note, guys, on the box below, no, that the membrane fluidity is mainly because of cholesterol. Okay, the fluidity, wag kayo malilito by the name, the fluidity of the cell membrane is due to the 13% cholesterol. It's not because of water, because your cell membrane has no water. Okay, and then the antigenicity of the cell membrane is basically because of your glycolipids. Okay, and then take note that yung water natin, nag-undergo siya ng osmosis via using your aquaporins. So dumadaan siya sa aquaporins para from one compartment to the other. The difference is kapag lipid-soluble and water-soluble substances. So if you're gonna recall, I hope you can see the arrow, yung mouse ko. Okay. So, di ba this is your lipid bilayer? This is your tail. Your tail is made out of fatty acids. So, if it's fatty acid, that means, guys, na lipophilic siya, right? So, lipophilic siya. And then always remember na if it's lipophilic, it's hydrophobic. Okay? So, opposite siya. So, that means itong mga lipid-soluble substances, they can pass through, they can penetrate the whole cell membrane because yung fatty acid tail mo ay lipophilic. Okay? And then, yeah, that's why the lipid-soluble substances undergo simple diffusion. Compared to your water-soluble substances na they need a carrier-mediated transport or they need an integral protein para makadaan sila from one compartment to the other. That is because yung phosphate head mo, the phosphate head is hydrophilic. Okay? The phosphate head is hydrophilic. However, yung mismong gitna ng body mo is hydrophobic. Okay? So that means pag may water-soluble substance ka, hanggang dito lang siya, no? Kasi water-philic yung phosphate head. Hindi na siya makakadaan all throughout kasi hydrophobic na siya. So gagamit siya ngayon ng integral proteins. Okay? So yun yung concept ng lipophilic, hydrophobic, and hydrophilic, lipophilic. Okay? Yeah, so these are the transports natin. We have the non-carrier and then we have the carrier-mediated transport. So if we're gonna do a crash course on this, so if it's high concentration to low concentration, no, pababa siya, it's pababa, so parang effortless tingnan, it's downhill, so usually diffusion. If it's low concentration to high concentration, it's uphill, right? So mas kailangan mo gumamit kayo ng energy kasi kailangan mo nang maging actively para ma-reach mo yung upper concentration, right? So if it's uphill, it's active. If it's downhill, it's diffusion. And in diffusion, we have two. We have the simple diffusion and then we have the facilitated diffusion. So usually, favorite nila yung facilitated diffusion. So I want you guys to mark on your handout now yung tatlong characteristics ng isang carrier-mediated transport, right? Di ba yung stereospecificity, competitiveness, right? And selectivity. So, yun. So, facilitated diffusion is downhill. However, it uses carriers. So, The next one is this one. If it uses ATP directly, okay, if you see in the question, uses ATP directly, it's primary active. So ito yung may mga ATPase sa pangalan like sodium, potassium ATPase, HK ATPase, calcium ATPase. However, if the question says transporter that uses ATP indirectly, that's a secondary active transport. Okay? So bakit indirectly? That is because yung mga secondary active transporters nyo, saan nakadepend? They depend on the sodium gradient created by the primary active. Okay? And then if it's going to the same direction, it's co-transport. If it's on the opposite direction, it's counter-transport. So for example, here, lahat ng may usually ang clue dyan, lahat ng may ATPase, primary active, lahat ng may mga sodium, lahat ng kasama ng sodium, madalas secondary active sila. So for example, we have this one. Your sodium-potassium ATPase pump here is a primary active, diba? So it brings sodium out of the cell and potassium in, diba? The mnemonic PISO, potassium in, sodium out. So what happens to the sodium intracellularly? Dahil nilabas mo yung sodium sa cell, dahil nilabas mo yung sodium sa loob ng cell, onti. So masisense ngayon ng cell mo na wait, ang onti na ng sodium ko sa loob. So kailangan ko magpasok ulit to maintain the equilibrium, no? So that means the sodium gradient created by the primary active, okay, is the one that will stimulate or that will activate your sodium hydrogen counter transport in this scenario. Okay? So sodium now will go in. Kapalit niya, so hydrogen will go out. Okay? Okay. So that's the first part ng cells natin, no, yung cell transport. It's very high yield, no? So very important siya, especially if you correlate it with your pharma. So for this one, which is an effective osmole, thus creates an osmotic pressure. Is it A, B, or C? So most of this, guys, actually everything in this lecture is lifted from your handout naman, okay? So it's actually letter A, no? It's an effective osmole, thus creating an osmotic pressure. So how come? Because by definition, osmolarity is the concentration of osmotically active particles, right? And then the higher the osmolarity of a solution, pag mas madaming osmolarity sa isang side ng compartment, the higher yung chances na mag-a-attract siya ng water going to that compartment. So for example, in image letter A, no, this is the cell membrane. As you can see, mga green circles, hindi talaga sila nakakatawid, no? Lahat sila naiipon lang to one side of the compartment. So ibig sabihin, ang taas ng osmolarity sa one side of the compartment. Thus, siya yung mag-create ngayon ng osmotic pressure to pull the fluid from the other side of the compartment. Okay? So ang RC na to, the RC na to is 1, no? The osmolarity coefficient na to is 1. However, if you're gonna go at letter C, the osmotic coefficient of 0, like your urea, ineffective osmole siya kasi hindi siya nakakagawa ng osmotic pressure. Kasi completely nagpe-penetrate yung solutes mo, no? So compared to letter A, sino ngayon mas mataas na osmotic pressure? It's your letter A, no? Kasi mas madaming solutes and osmotically active particles on one side, so mas mataas yung chance na magpupull siya ng fluid, okay? So very important example here is your albumin and then your urea. Albumin is 1 and then urea is 0. Okay, so for this one, in the muscle contraction, which structure is immediately responsible for release from the sarcoplasmic reticulum? Responsible for calcium release pala from the sarcoplasmic reticulum. So this is your RYR channel, right? So here. So before we proceed there, let's recall your neuromuscular signaling steps. So if you can see, guys, I'm not going to every detail na inyong handout because this is just our review. So in summary, so hopefully I'm focusing on the usually must knows and high yield for the boards, no? And then everything else na hindi ko ma-cover is I hope you can go through them pa din, okay? So let's start with the neuromuscular signaling steps. So number 1, magkakaroon ka ng action potential, right? So the action potential pupunta ng presynaptic terminal buttons, right? So this will activate your voltage-gated calcium channels, okay? Now, calcium will influx. It will lead to your, anong tawag dito? It will lead to the docking, okay? Docking, letter number 3, docking of the vesicles containing the neurotransmitters. So dahil nagda-dock na yung vesicles, ibig sabihin, dumidikit na siya sa presynaptic membrane, okay? So once in the presynaptic membrane, it will undergo exocytosis and then eventually release your neurotransmitter, okay? Number 4. And then number 5, take note here that your, for example, acetylcholine here will bind to your nicotinic receptors on the postsynaptic, and it will increase, okay, take note, it will increase conductance to both, okay, to both sodium and potassium, not just sodium, both sodium and potassium. However, it's the sodium influx that's responsible for producing the miniature end plate potential. So if you have the miniature end plate potential, pagsama-sama mo yung mga yon, you will have your end plate potential. And then eventually, you will have your depolarization of your sarcolemma. So that depolarization now will go to your transverse tubules. And in the transverse tubules, okay, number 2, nandyan yung DHP receptors nyo, okay? So once activate yung DHP receptors, okay? So mnemonic ko here is doctor. Mauna si D bago si R. So dihydro bago si ryanodine. Okay? So dihydro, okay, your DHP receptors will be activated so that it can activate yung ryanodine receptor channels mo. So yung RYR channel mo ngayon in the sarcoplasmic reticulum, siya yung mag-active, siya yung mag-open para i-release yung calcium inside the sarcoplasmic reticulum. Okay? And then that calcium will eventually go to your troponin C. Okay? So now yung troponin C, it will lead to the exposure, shifting ng tropomyosin para magkaroon ka ng myosin binding sites. So this is actually very an important slide as well. No, yung importance ng mga ATP, ADP, and complete hydrolysis, right? So let's start with number 1. Okay, number 1 mo, si calcium, nag-bind na siya, di ba? So na-expose na yung binding site. So what happens next is a new ATP will bind to the myosin head. This new ATP, itong panibagong ATP na to, siya yung dahilan kung bakit magde-detach ngayon si myosin kay actin. Okay? So itong ATP will undergo partial hydrolysis. So partial lang because you will have ADP plus the inorganic phosphate. Okay? So kapag partial hydrolysis, number 3, that's called your recocking. Kasi 'di ba ito yung myosin mo, magre-recock siya, pupunta siya sa positive side. Okay, from this one, kaya ganun siya. So that's your recocking. And then eventually, your phosphate will be released, leaving na your ADP. So kapag ADP, it will now bind to the actin again, right? And then once nag-hydrolyze na completely yung ADP mo, look at image number 5, wala ng ADP. That's now your power stroke or your force generating stroke. So that means kanina, kung sa positive end siya during recocking, pupunta siya ngayon sa negative end, okay? So pag recocking, go to the positive pole. Kapag power stroke, go to the negative pole. Okay? So parang hinihila ngayon yung actin. Okay? Okay. Sodium influx is responsible for depolarization or phase 0 in which action potential. Saan daw nagkakaroon ng sodium influx? Nerve action, ventricles atria, SA node, or lahat yan? So very important, very important. We have your nerve action potential and ventricles and atria. Okay? Hindi kasama yung SA node dyan. So that's kaya kung sabing important kasi usually guys in studying for the board exam, aside from understanding the must knows, hanapin nyo kung ano yung mga peculiar o yung mga unique sa mga binabasa nyo. Kasi usually, there's a tendency na yun yung kukunin nila or yun yung itatanong nila sa inyo. Okay? So for example, in this one, phase 0, sodium influx depolarization, nerve action, potential, ventricles atria, except for SA node and AV node ng heart. So not all of the heart, right? So your resting membrane potential ng nerve is negative 70 millivolts. So it's maintained by 3. Okay, tatlo yung factors dyan. Yung Nernst potential ng sodium-potassium, potassium leak channels, and then sodium-potassium ATPase. Now, madami ding pwedeng itanong sa RMP. So for example, during RMP, saan siya mas permeable? Potassium or sodium? Okay, it's more of potassium. During RMP, saan siya mas malapit sa equilibrium? Sodium or potassium? Potassium din. Kasi if you're gonna take a closer look sa last bullet, your equilibrium potential ng potassium is negative 85. Your sodium is positive 65. Sobrang layo sa negative 70 millivolts ng nerve, right? So, usually, potassium, mas mataas ang permeability niya sa resting membrane potential. Plus, if you're gonna look at numbers 1, 2, 3, lahat yan may potassium, no? So, mas powerful si potassium in the resting membrane potential. I mean, not powerful, but mas permeable siya, okay? So depolarization usually is because of sodium influx. Repolarization is due to potassium efflux. And then hyperpolarization is because of the delayed closure ng ating potassium channels. So tuloy-tuloy lang yung paglabas ng potassium during hyperpolarization. Okay, this is what I was pertaining to. This is your ventricles, atria, and Purkinje system, right? So you have your phase 0, 1, 2, 3, and 4. This is your SA node. As you can see sa SA node, wala kang phase 0, wala kang phase 1 and 2. You only have 4, 0, and 3. Okay? In the ventricles, phase 0 is because of sodium influx. Your depolarization is because of sodium influx. However, in the SA node, your phase 0 is because of influx ng calcium. Right? So, unique yun sa kanya. So, kung ako yung board examiner, pwede ko yung tanong yun para pampalito sa test takers, no? And then, we have also your phase 4, your resting membrane potential. Your phase 4, as you can see, sa SA node, hindi siya naka-flat lang, no? Hindi siya diretsong ganyan. Slowly siyang umaakyat. And that is because the phase 4 in the SA node is because of sodium influx, no? Kasi you have your sodium funny currents there, kaya siya IF. You have your sodium funny currents here, kaya nagkakaroon ka ng steady increase ng phase 4. And then phase 3 on both ends, same lang yan, potassium efflux. Okay, so another peculiarity or unique feature in this slide, you have your phase 2 plateau. Okay, your phase 2 plateau is a balance between potassium efflux and calcium influx. Okay, so that's mainly found in your ventricles, atria, and the Purkinje system. So just by this graph, no, pwede silang madaming pwedeng kunin na possible questions dito, okay? So, okay, so neurophysiology. So, ang tip ko pala for physiology, it's mahirap talaga ma-memorize everything, no? Pero if you can explain the concept sa sarili mo, kung paano ka nag-aaral o paano ka nagtuturo, I believe that's really, really helpful, okay? So, let's go to neurophysiology. Okay, so autonomic nervous system. So the autonomic nervous system is one of the favorites for both physio and pharma. Okay, so if I really do recommend na you have to memorize or master yung mga preganglion and postganglion and even the receptors. Okay, so let's start first with your somatic nervous system. The somatic nervous system is a one neuron system. Isa lang siya, no? So gamit niya acetylcholine. So cholinergic transmission siya. Under autonomic, you have your para and you have your sympathetic nervous system. Your para is for rest and digest, galing siyang craniosacral. Your sympathetic is for fight or flight, galing siya ng thoracolumbar. So you also have to know then anatomically, no, yung kanilang locations, no, aside sa origin, pati yung length ng mga ganglion. So for example, si sympathetic, siya yung may short pre and long post. So ako noon, sabi ko lang sympathetic short pre. Ganun ko lang siya inaalala, no? So sympathetic short pre. So, alam ko ng post ganglion niya is long, and then opposite niya si parasympathetic. Okay? So you have to take note, guys, na although not in this slide lahat, na there are two modified sympathetic organs or innervation. So that's your adrenal gland, so modified sympathetic, and your sweat gland. So bakit sila modified sympathetic? Kasi if you're gonna take a look at the adrenal gland here, it releases norepi and epi. Diba? So sympathetic. However, isa lang yung neuron system niya. Right? So tapos, ang inalabas niya is acetylcholine. So even though na part siya ng sympathetic nervous system, no, acetylcholine lang yung ginagamit niya pang stimulate, and then one neuron system lang siya. So it's a modified sympathetic. Another one is not in this image is you have your sweat gland. Your sweat gland is also a modified sympathetic because it's a two-neuron system. So meron siyang pre-ganglion and post-ganglion. Pero on both end, okay, acetylcholine yung ginagamit or nire-release ng ganglions mo. Okay, so modified sympathetic sila. So this is one of their favorite, no? So I hope ma-master nyo kung sino-sino yung mga cholinergic transmission. So when we say cholinergic, yung gumagamit ng acetylcholine. So all pre-ganglionic, both para and both sympathetic. Okay? Next is post-ganglionic ng parasympathetic. Next is post-ganglionic neuron ng sweat gland. Okay, not here in the image. And then your somatic nervous system. Yan yung mga gumagamit ng acetylcholinergic transmission. So this is the mnemonic given to us by Dr. Rolly in our handout, right? The plasma. So very helpful to pag na may mental block na kayo. Okay, so is this table important? Actually, this is very important, no? Kasi in this table, makikita niyo yung mga receptors and then yung mga actions nila, no? So technically, if you want to sum it all up, no, sympathetic lahat nagpapataas halo, no? Halos nagpapataas at nag-i-increase. Yung parasympathetic nagpapa-decrease. So usually what the examiners would do is would pick out ano yung mga kakaiba or yung unique sa kanila. So for example, pag sinabing bronchial relaxation, is it sympa or para? Diba? It's more of sympathetic because your bronchodilation is part of your sympathetic nervous system. Pag sinabi mong increase in GI motility, no, leading to possible diarrhea, ganyan. So increased GI motility, initially akala baka isipin nyo sympathetic kasi increase, no? Pero again, rest and digest, that's a parasympathetic action. Okay? So you have to at least be familiar with the receptors ng mga bawat organs and their actions, specifically yung mga unique actions. What's more important in this part is yung mga receptors, okay? So in the adrenergic system, you have your alpha 1, 2, beta 1, 2, and you even have your beta 3, right? So yeah, so they use your G protein. So kapag GQ, that increases your IP3 and calcium. Kapag GS, increases your cyclic AMP. And kapag GI inhibitory, decreases your cyclic AMP. So you also have your cholinergic transmission. Your cholinereceptors, rather. You have your M1 that increases your IP3. M2 decreases your cyclic AMP. And then M3 increases your IP3. Okay? And then you also have your nicotinic receptors. So para mas madali, no, you have this mnemonic in your handout as well, yung KISS and KICK. So start ka kay alpha 1, alpha 2, beta 1, beta 2. That's your KISS. So GQ, GI, GS, GS. Okay? So GQ, increase IP3. GI, inhibitory, decrease cyclic AMP. Then GS, stimulatory, is increased cyclic AMP. And then on the other side, yung kick mo is yung cholinereceptors, right? So that's your kick, M1, M2, M3. So M1 and M3, okay, sila increase IP3, and then M2 is decreased cyclic AMP. So para kapag tinanong kayo sa exam, no, or sa boards nyo, parang kanya nagbigay sila ng action. For example, dilates bronchial smooth muscle. Alam mong B2 siya, beta 2. Pero ang tanong sa iyo is ano yung MOA niya, right? They can do that, ha? Ginagawa nila yon. So you have to be familiar with this table and their actions. Okay, next we have your fibers. I think we also have a table in your handout here. So itong part na to, ganito ko siya inaral before when I was studying for the boards, no? Sina-side by side ko siya. So for example, when you say largest fiber diameter, I'm talking about, guys, yung A alpha, A beta, A gamma, A delta, type B or C fibers, right? So when you say largest fiber diameter, syempre kung may largest, meron kang smallest fiber diameter, right? So ganito ko siya inaral, no? So si largest, si A alpha, si smallest, si type C. If meron kang thickest myelin, you have your unmyelinated. Okay, so thickest myelin, A alpha, and then you have your type C as well. Kapag may fastest, meron ka ding slowest. Okay? So if you're gonna look at the table there mamaya, I have it here naman, merong fast pain. Yung pag kinurot ka, masakit agad. Okay, that's alpha delta. You have your slow pain, like for example, burning pain. That's your type C as well, no? You have fibers for your preganglion, and you also have your ganglions for your postganglion. You have your primary sensory afferent ng muscle spindles. You also have your secondary. Okay? So yung point ko lang here is, if you're given a table like this, okay, itong table na to, it's if you can, no, kung kaya nyo hanapin yung magkakatumbas, para mas madali kayong maalala. Mas madali nyo siyang maalala, no? So yun yung tip ko for this type of tables. Okay? So basically, type A, specifically in type A alpha, has the fastest conduction velocity. Siya yung thickest, siya kasi mas myelinated siya. Okay? So itong mnemonic na to is my personal mnemonic before is HPA, BAC. So walang point na mnemonic pero nag-stick siya sa akin, no? So HPA, BAC. Your prone to hypoxia is type B. Yung prone to pressure is type A. Yung prone to anesthetics is type C. Okay? So, I don't know why it stuck with me, pero yeah, sinishare ko na din siya. So, HPA back. So, hypoxia, B, pressure, A, anesthetics is type C. Okay? So stretch reflex. So during stretch reflex, answer on your own. So muscle spindles use 1A and 2 afferent fibers. What is the efferent neuron of this intrafusal fiber? So ano daw yung pang motor pathway naman? So the answer here is your gamma motor neuron. Okay? So if you know this mnemonic, diba, you're gonna be able to answer that question earlier. So AGs, right? The band. I hope kilala nyo sila, no? So alpha fibers is for extrafusal and then gamma fibers is for intrafusal fibers. Okay? However, I've also made this mnemonic. So when I teach in San Beda, I teach this to my students as well. So I love you, Eka. So that means is yung I love you mo is your intrafusal fibers is mainly for muscle length and it's innervated by your gamma motor. Okay? And then si Eka, your extrafusal fibers is mainly for muscle contraction and it's innervated by your alpha motor neuron. No? So if you're gonna combine ages and then I love you, Eka, whatever they do, if they're gonna paikot-ikutin nila kayo sa questions, you're gonna be able to answer kung ano yung function nila and ano yung mga motor fibers nila. Right? Okay. So let's briefly talk about this stretch reflex, for example, no? Okay, let's start here. Okay, so briefly lang, I want you to listen lang, no? So for example, we have knee-jerk reflex or quadriceps reflex. You will stimulate mo yung muscle spindles mo, right? The muscle spindles acting as your receptors in this scenario. So quadriceps reflex, knee-jerk reflex, di ba? Hit mo yung tuhod, hit mo yung tendon, and then mas-stimulate mo yung muscle spindle reflex. So if tinanong kayo, what is the sensory pathway or what is the afferent fiber of the reflex? It's either 1A afferent or the 2 fibers, no? But the primary afferent is 1A. So 1 na siya, A na siya na yung primary afferent mo, no? Secondary afferent mo is yung type 2 fibers. So, since afferent siya, since sensory siya, pupunta siya dito sa dorsal horn ng gray matter ng spinal cord, right? And then sa gitna, sa mismong gray matter ng spinal cord, andyan yung mga interneurons mo. So, two concepts I want you to take note in this part, okay? Your sensory fiber, your 1A afferent fiber will directly synapse with the alpha motor neuron of the target muscles. So for example, in our scenario, directly synapsing siya sa alpha motor neuron ng quadriceps muscle. Okay? And then it will also synapse with the inhibitory interneuron. Itong color white, okay? That's your inhibitory interneuron, which means that your afferent fiber will stimulate the interneuron to inhibit the antagonistic muscle. Okay? So again, your sensory afferent fiber will directly innervate the alpha motor ng target muscle, yung gusto mo pagkontrahin. However, kung may gusto ka pagkontrahin, gusto mo may magre-relax, 'di ba? Para hindi magkalabo-labo yung stretch reflex mo, right? So in that scenario, you have to relax the counter muscles or the antagonistic muscles. To relax that, kailangan stimulate ni afferent fiber si inhibitory interneuron para siya yung mag-i-inhibit sa antagonistic muscles. Okay? So the antagonistic muscles are not inhibited directly by the afferent fibers. They're directly inhibited by the interneurons. Okay? Yan. So muscle spindle, L. So spindle is for length. And then once nasobrahan ka na ng contraction and tension, you will activate your Golgi tendon kasi siya nag-detect ng tension. Okay? So again, afferent mo is 1A and 2 for muscle spindles. And then Golgi tendon is 1B. So this one is one of my, pardon my drawing. Pero yan yung drawing ko since nag-aaral ako ng board. So never ko na siya pinalitan. Okay? So you have two types of infrafusal fibers. You have your nuclear bag and you have your nuclear chain. I know you have your mnemonic here as well, pero let me share mine. No? So between bag and chain, ang pinaka natatandaan ko dito is nuclear chain. No? Just imagine a man na naka-chain yung dalawang paa niya. So since dalawang paa niya naka-chain, ang ginagamit niya is group 2 afferents. Right? Tapos since naka-diretso yung chain mo, yung position niya is naka-rows siya. Right? So another one, since dahil nakakadena yung paa niya, gumagalaw ba siya? Hindi. So it detects your static changes. Okay? So I know it's a bit weird mnemonic, visual mnemonic, pero for me, yun yung nag-work. So I hope may sense siya. No? And then kapag nuclear bag, it detects dynamic changes kasi if you have your bag here, di ba, on your shoulder or on your elbow, when you're walking, laging gumagalaw yung bag mo. So it detects dynamic changes. That it uses 1A afferent fibers. Okay? So very important tong mga muscle spindles like bag and chain. Okay. Neuro. So lesion or transection at the level of the brainstem. So when you say brainstem, it's midbrain, pons, medulla, right? Brainstem is midbrain, pons, medulla. Ano daw yung manifestation? Ipsilateral or contralateral? So you will have, at the brainstem level, you will have contralateral weakness, contralateral loss of proprioception and vibration, and then contralateral loss of pain and temperature. So bakit ganyan? So there are 3 important pathways sa neurophysio. So that's the first one is your main descending pathway, descending. So main motor siya. It's your efferent pathway, your pyramidal tract or your corticospinal tract. So they don't really go into the minute details of the pathways, pero more of more of the scenarios and more of the situations or the decusation sila usually nag-highlight, right? So for example, we have the corticospinal tract, okay? The corticospinal tract in this image is the descending, no? Descending, going down, efferent, going down, and motor siya. So the decussation of this one is nasa cervicomedullary junction, no? So na lower medulla. So that means na when you say decussation, going to the other side, no, tatawid na siya. So just imagine, no? When we say na meron siyang lesion above the decussation or before the decussation, hindi pa siya tumatawid, that means your manifestation will be on the opposite side, contralateral side. Kasi ang decussation niya is nasa lower medulla pa. However, when we say you have this patient na may mahabang case, tapos nakita mo meron siyang transection sa spinal cord level, okay? Sa spinal cord na. Your manifestation now will be ipsilateral on the same side. Bakit siya magiging ipsilateral? That is because ang decussation nitong pathway na to ay nasa lower medulla. So, tumawid na siya sa kabilang side. So, kapag spinal cord na tinamaan mo, same side na kasi nakatawid na siya. Okay? So, we also have your 2 important afferent pathways. Yung dalawang sensory pathways mo, si dorsal column for proprioception, vibration, and then your spinothalamic tract na commonly known for pain and temp function, no? So si dorsal column medial lemniscate pathway naman is also decussate sa lower medulla. Okay? Ang pinagkaiba nila, when we say pag meron kang lesion before the decussation, so ibig sabihin hindi pa siya nakakatawid, right? So manifestation niya is on the same side. So kanina sabi ko, brainstem lesion. Ang decussation kasi ng dorsal column mo ay nasa lower medulla. So nakatawid na siya. So dahil nakatawid na siya, ang manifestation mo na ay nasa contralateral side. Okay? And then for your pain and temps, spinothalamic, always yan, will be always on the contralateral side, regardless kung brainstem or spinal cord, because it will decussate immediately. Okay? So kapag spinal cord naman, ipsilateral weakness, ipsilateral proprioception loss, and then contralateral pain and temp loss. Okay? So very important to kapag nagbigay naman sila ngayon ng mga spinal cord syndromes. So okay, I know it's kind of confusing, pero just remember kung saan sila nagde-decussate. And then if bigyan kayo ng ganitong case, tandaan nyo, tumawid na ba siya o hindi pa tumatawid? Ganon. Okay? Decorticate versus decerebrate rigidity, one of the physiologic concepts, neurophysiologic concepts na favorite nila. So when you say decorticate posturing, yung lower extremity mo naka-hyperextend, and then yung upper X mo naka-flex. So, decorticate, magbuo kayo ng O kapag nag-flex kayo, ganyan. Hindi kita pero like, ganyan. Basta i-flex nyo yung hands nyo, magbumukha siyang O, right? So, that's your decorticate rigidity. Kapag decerebrate rigidity, both upper X and lower X naka-hyperextend. Okay? So, ang usual question dito is usually ano yung tracts involved, ano yung tracts na spared, bakit siya decorticate, right? So take note that your decorticate is any lesion above the midbrain. Okay? Any lesion above the midbrain yan, decorticate usually, no? Bakit above the midbrain specifically? Because your rubrospinal tract comes from the red nucleus, red nucleus ng midbrain. So any lesion above the midbrain, ibig sabihin hindi mo pa dinadamage si rubrospinal tract. Okay? So intact si rubrospinal tract. So magfe-flex pa yung upper extremity niya. Compared kapag kay decerebrate rigidity, that's a lesion at the level of the midbrain or below the midbrain. Yung pathway ng rubrospinal tract na nag-stimulate ng flexors, tinanggal mo na. So decerebrate na din yung upper extremity mo. Okay? So these are your extrapyramidal tracts, by the way. So for me, aside sa rubrospinal tract, ang technique ko dito is just like yung kanina, yung side by side ko yung magkakatulad. Ko naman dito yung mga opposites. Like for example, si rubrospinal lateral vestibulospinal tract. Si rubro mainly flexor siya. And then si lateral vestibulospinal tract main extensor naman siya. Okay, what else? We have here your pontine and your medullary reticulospinal tract. Si pontine stimulates both but mainly extensors. Si medullary reticulospinal tract inhibits both mainly extensors. So if you're gonna compare the two, si pontine, okay, dalawang plus, so stimulates both but mainly the extensors. Opposite niya si medullary reticulospinal tract. Okay? So I'm just showing you possible ways on how to recall this mga certain diagrams and certain tables. And then yung natitira is you have your medial vestibulospinal and then your tectospinal. Tectospinal is orientation of head and neck during eye movement, and then medial vestibulospinal tract is controlling the neck muscles. Okay, let's now go to your cardiophysiology. So, syempre, we have yung mga ating mga vessels, yung mga ating arterioles, arteries, capillaries. So, this is also very high yield for your anatomy. So, One way, another tip, so as you can see, nagbibigay ako ng tip as we go along. So, if meron kang topic or part ng certain handout na pwede mong i-correlate sa other part ng subjects, mas I suggest you do it. No? Kasi it will help you sa retention eh. Okay. So for example, this one, arterioles, your arterioles mo yan yung site of greatest resistance. So is the one responsible for controlling the blood flow or the conduits. That is because if tinanong ka bakit yung arterioles, because they are capable of rapidly dilating and constricting. Your arteries, di ba? Recall your anatomy dissection, di ba? Your arteries compared to the veins, pag laging pinipinyan magkatabi, laging confusing, right? Very confusing kung ano yung artery, ano yung vein. Tinitingnan natin dyan kapag arteries, thick-walled sila. Thick-walled. Kasi may meron silang makapal na muscular layer. So dahil makapal yung muscular layer nila, they're capable of containing a huge amount of pressure. So high pressure sila, and they're containing the stress volume. Although not in this table, no, kapag may stress volume, pag nagtanong, saan yung unstressed volume? Yung unstressed volume mo na kay veins naman. Okay? Yung veins mo kasi ngayon, sila yung capacitance vessels kasi very thin-walled sila. So, they can contain most of the blood. So, actually around 64% based on this, based on our handout, right? And then we have your capillaries. Your capillaries has the largest cross-sectional area, making it possible for blood, for gas exchange. No, the higher the cross-sectional area, the slower the blood velocity. That is because, syempre, kailangan mo ng slower blood velocity para maging adequate yung exchange ng mga substances and materials. Okay. Okay. So we have here yung mga important hemodynamics, yung mga formula. So important ba to? So actually, yes, they're very important. No? Specifically na for this specific slide, no, they do ask you computations sa boards, ha? Mind you. So in our boards, nag-ask, I think we had 2 computations on renal. And then the next board, nagpa-compute sa cardio. And then after that, sa respi naman. Okay? So I'm not sure kung anong system sila ngayon, no? Pero this specific slide, hindi ka masyadong magko-compute sa part na to, but what's more important is for you to know the concept, no, the basic tenet na mga to. Every time you're gonna see a formula in physiology, just always remember yung concept ng fraction. Kapag numerator siya, kapag nasa above siya ng fraction line, usually directly proportional siya to what happens to the outcome, right? Kapag nasa denominator siya, usually opposite or inversely proportional, right? So for example, we have your blood flow velocity. So pag sinabi ni sa question, nag-increase yung blood flow, what will happen to the blood flow velocity? Nag-increase yung numerator mo. So obviously, your product or your output will also be increased. Okay? So kapag naman sinabi mo, nag-increase yung cross-sectional area, nag-increase daw yung denominator mo in this part, okay? So what will happen to the blood flow velocity? Since nasa denominator siya, opposite siya, okay? So increased cross-sectional area, you will have a lower blood flow velocity, okay? So yun lang yung gusto kong i-emphasize for this types of formula, no? Yung mga fraction. Like for example, sa ating Poisson law, sa ating resistance, your resistance will increase kapag tumaas lahat ng numerator mo. Kapag tumaas yung viscosity mo, kapag tumaas yung length ng blood vessel. However, if kapag tumaas yung denominator mo, which is the radius, your resistance will actually decrease. Kasi pag tumaas yung radius ng blood vessel, mas lumuluwag yung lumen, no? So decrease na yung resistance niya. So that principle goes as well with the laminar versus turbulent and as well as your capacitance. Okay? So you have to know kung ano yung mga ibig sabihin ng mga symbols na yan. Okay? So yeah, so this is very important and most of the usually the principles and the concepts behind the formula para ma-apply nyo siya sa mga situations or cases if they're gonna give any cases. So another part of the hemodynamics, we have this part. Your stroke volume is around 70 ml. So mind you guys, if in physiology, if merong mga normal values, tapos if yung mga normal values na yon possible mong ma-substitute to a formula, tandaan nyo yun. Okay? So there's one, I remember one of my friend told me na meron daw parang correction sa PLE kasi nagpa-compute ng cardiac output pero ang binigay lang heart rate. So yung iba na-compute, yung iba hindi. Kasi syempre nakaka-panic na din naman yun, no? So pero if you know the normal value of the stroke volume, okay, sorry. If you know the value of the stroke volume, kaya mo compute yung cardiac output na yun kahit wala yung stroke volume sa given. Okay? So stroke volume is EDV minus ESV. So that's basically the blood ejected per ventricular heartbeat. Your preload is approximated by your end diastolic volume. Your afterload is the tension that the left ventricle must develop in order to eject the blood, or the resistance that the left ventricle must overcome. And then we have your end systolic volume, or the volume after contraction. Kaya nga siya end systolic, right? End systolic volume, volume after systole, right? So end diastolic naman is the volume after diastole or after relaxation before contraction. Okay? So, yan. Very important yung mga concepts na to, right? So preload as approximated by your end diastolic volume. Okay, for the cardiac cycle mismo, this one, I really do suggest na if you can master this diagram, and not just the ventricular pressure, no? Kasi as students, kahit ako before, I just look at the ventricular pressure curve, yung color red, no? However, the best way to tackle this is if you can correlate it with all of the other pressures, with all of the other lines in this diagram, right? Okay. So let's start with usually with your atrial pressure, atrial contraction, atrial systole. So kapag nagkaroon ka ng atrial systole, your atrial pressure will slightly increase, right? And then your ventricular volume in color blue and then in color red na ventricular pressure will actually slightly increase then. Diba? If you recall, the left ventricular blood filling, no? It doesn't really depend on atrial contraction. No, onti lang yung amount ng blood na pupunta sa left ventricle kapag nagko-contract si atria. Right? So kaya onti lang din ang increase niya. And then eventually, if your left ventricular pressure is greater than your atrial pressure, your AV valves will now close. This will now signify the start of the isovolumic contraction, wherein meron kang constant increase in pressure kasi nagko-contract si ventricle, but your volume is the same kasi naka-close lang siya. And then eventually, your left ventricular pressure will be greater than the aortic pressure. So it will push open the semilunar valves like your aortic valve, leading to your rapid ejection and then eventually your reduced ejection. And then eventually, kapag yung left ventricle is less than the aortic pressure, no, the aortic valve now will close, signifying the isovolumic relaxation, wherein pressure decreases kasi nasa diastole ka na, and then the volume is constant kasi naka-close yung both valves mo, right? And then eventually, since nasa diastole ka, once your left ventricular pressure is less than the atrial pressure, you will now open again yung iyong AV valves or the mitral valve in our example. So pag nag-open na yun, magkakaroon ka ng rapid ventricular filling even without the atrial contraction. Okay? So that's the ventricular pressure, no, usually. So for me, I want, if you can, no, i-correlate nyo saan lumalabas si A wave, si C wave, si V wave, right? Si diastasis, si necrotic notch, yun yung mga hinahanap usually ng mga board examinees. Okay, another important concept in physiology is yung ating baroreceptor. So kapag nag-expire ka against a closed glottis, you actually increase your intrathoracic pressure, thus decreasing the venous return. Pero ang question here is what will happen to the firing of cranial nerve number 9 or the hearing nerve? Your cranial nerve number 9, diba, is your parasympathetic. So in this scenario, it will be actually decrease. Okay? So magde-decrease siya. So bakit? Kasi if you have a low BP, decrease yung stretch ng iyong carrot ng iyong mga receptors sa carotid ng pag mababa ang BP mo, magdi-decrease yung stretch mo, right? So dahil nag-decrease yung stretch mo, madi-decrease ngayon ng firing ng cranial nerve number 9 to the nucleus tractus solitarius. So basically, decrease ang parasympathetic effect mo in effect to increase your sympathetic response. Kasi mababa yung BP mo, di ba? So kailangan mo yung sympathetic para itaas siya ulit. Compared kapag mataas ang BP mo, mataas ang stretching mo, ma-activate mo ngayon si cranial nerve number 9. Thus, i-activate ni cranial nerve number 9 yung parasympathetic response to decrease the BP back to normal. Okay? Okay. Okay, I hope okay pa tayo. So let's go to respiratory physiology. Okay, so for gas exchange, anong cell to? 1. For surfactant production, type 2 produces mucous goblet cells. So your Clara cells or club cells is mainly for production of protective glycosaminoglycans and as well as metabolizing airborne toxins. While your dust cells or the macrophages, yung nagpa-phagocytose naman ng mga agents and mga toxic substances. Okay, so surface tension is an important concept in respiphysio. So by definition, is the force caused by water molecules at the air-liquid interface that tends to minimize surface area. So take note of the law of Laplace, okay, or Laplace. So again, by fraction, kapag mataas yung numerator, like the surface tension, the collapsing pressure is actually high. Okay, if the radius is high or if the denominator is high, the collapsing pressure is lower. Okay? Your surfactant decreases surface tension that will decrease the collapsing pressure, preventing your alveolar collapse. Kaya di ba kapag mga preterm in your handout din, if it's written there, kapag ang preterm, wala pang surfactant. So yung surface tension, yung numerator nila mataas. So yung collapsing pressure nila mataas din. Right? Yan. So take note of this as well, the important must-knows ng ating lung surfactant. Okay, let's go to the volume curve. So let's go to the volumes and capacities, okay? So what volume is this or what capacity is this? Air inhaled during relaxed state. This is your tidal volume. Air that can still be breathed in after normal inhalation is your inspiratory reserve volume. How about this one? Air that can be breathed in after normal exhalation. This is actually your inspiratory capacity. Okay? So air that can still be breathed out after normal exhalation is your expiratory reserve. And then air that remains in the lungs after maximal exhalation is your residual volume. Okay? So ito yung topic in respiphysio na mukha siyang madali, pero kapag sinide by side na siya na examiner, nakaka-confuse na siya, no? So ang technique ko dito is you really have to know your tidal volume kasi from there kaya nyo ma-derive yung answer. So kanina sabi natin, relaxed state. So normal inspiration, normal exhalation, that's your tidal volume. So air that can still be breathed in, yung kaya mo pa i-inhale after normal inhalation is your IRV, right? So your ERV naman, your expiratory reserve volume, that's the volume after normal exhalation. Okay? Normal exhalation kasi normal exhalation mo si tidal volume, right? So ano pa ilalabas mo after that? That's your ERV. And then the air remaining after maximal, this one, that's your residual volume. Yung inspiratory capacity mo natin kanina, sabi natin, it's the air that can be breathed in after normal exhalation. Kasi after normal exhalation, you're gonna start again your tidal volume plus your IRV. Eh, di ba yung IRC is a combination of tidal volume plus IRV. Okay, so for this one, just always go back to the tidal volume as your landmark. So most importantly, correlation with patho and IM as well is we have your obstructive versus restrictive lung diseases. Your obstructive diseases like your COPD or asthma is a problem with exhalation or expiration. So your forced expiratory volume will be lower compared to the low FVC. So by fraction again, no, dahil mas malaki yung binagsak ng numerator mo, yung ratio mo mababa, right? Compared to your restrictive lung diseases naman like fibrosis, mas mababa yung FVC, mas mababa yung denominator. So yung ratio mo ngayon will either be increased or it can also be normal. Okay? So we all have here the important control centers. We have your DRG, dorsal root, that generates the basic rhythm. We have your VRG, that's force inspiration and expiration, and we have your pula. So that's pneumotaxic from the upper pons, and then apneustic from the lower pons. So your pneumotaxic shortens the time for inspiration. So usually nakakaroon ng lituhan dito, no? When you say shortens the time for inspiration, hindi mo dinidecrease yung RR, okay? When you shorten the time of inspiration, mas ini-increase mo yung RR, mas pinapabilis mo siya. Okay, that's pneumotaxic. Kapag apneustic, pinoprolong mo yung inspiration. Thus, mas magde-decrease yung RR kasi mas pinapatagal mo yung inspiration. Okay? So that's your pneumotaxic and your apneustic. Okay, so this one, you have your oxygen hemoglobin dissociation curve. So tandaan nyo si Kabet, right? Very high yield mnemonic, no? Shift to the right siya. It will shift to the right basta kapag kailangan ng muscles and ng body mo ng oxygen, right? So shift to the right, decrease affinity kasi ini-increase mo yung unloading. Okay? Shift to the left kasi nag-increase yung affinity, mahal na mahal ni hemoglobin si oxygen. So, increase affinity. Dahil mahal na mahal niya, ayaw niya i-let go. So, decrease oxygen unloading. Okay? So, be familiar with the kabet. Okay? So, yun yung mga factors that would increase the oxygen unloading para mag-shift to the right C curve. So, okay, for this one, let's try. Expected VQ, patient presented with sudden onset dyspnea after prolonged immobilization. This is actually your pulmonary embolism, right? So, VQ mo is infinite. So, briefly lang, kapag Q is perfusion, V is ventilation, right? Individually, higher sila sa base. But VQ is higher in the apex. That's because your Q, your blood, is denser than air. Okay? So, mas mataas ang VQ sa apex. Kaya pag sinabi nating patient has high VQ, that means meron siyang mataas na oxygen and low carbon dioxide. When you say a patient has low VQ, meron siyang low oxygen but high carbon dioxide. Okay? So this one is also one of my favorite mnemonic. Now, this is not mine, pero I've been using this, no? Kasi it's very high yield, no? Kapag meron kang shunt problems or shunt sa intrapulmonary shunts, that means your VQ is 0. When it's 0, that means you have airway obstruction. So if it's VQ 0, you have no ventilation, but you have perfusion. Airway obstruction like pneumonia, edema, okay? Kapag naman infinite, that's dead space ventilation. Since dead space ventilation siya, that is a blood flow obstruction, okay? Yung dalawang O ng blood, gawin mong infinite, right? So blood flow obstruction, no perfusion with ventilation naman siya, okay? So ang madami example is si shunt, si VQ0. Si dead space, VQ infinite, madalas si pulmonary embolism kasi blood flow obstruction. Okay. Renal and acid-base physiology. So, okay. So, remember the 60-40-20 and 15-5. Okay, 15% of the ECF is interstitial fluid, and then 5% of the ECF is your plasma. Okay, they can ask you the mga stuff about this, mga basic computation, like gantong certain kilogram of patient, ilan yung kanyang ICF. Okay, so just know the percent itong mga mnemonic na to. Okay, for this one, I know this can appear as overwhelming, no? Pero hinighlight ko dito yung mga naka-red kasi for me, when studying this diagram, look at the initial scenario o kung ano yung possible nag-i-initiate ng sequence of events. Okay? Okay, so for example, when we have, let's look at sweating. Okay, sweating tayo. Hyperosmotic volume contraction, right? Pag nag-sweat ka, nag-release ka ng skin, right? Your ECF volume will decrease kasi ECF volume will decrease. When your ECF volume decreases, okay, what happens to the osmolarity ng ECF? The ECF osmolarity will increase kasi tinanggalan mo siya ng fluid kasi pinawis mo na siya. So your ECF osmolarity will then increase. So dahil mataas yung ECF osmolarity mo, okay, by our kinase osmotic pressure in our cell tissue, it will now pull the water from the ICF to the ECF. So your ICF volume will decrease kasi hinatak na siya ng ECF osmolarity mo. Right? So dahil nawalan ka naman ng fluid ngayon sa ICF, what will happen to your ICF osmolarity? It will now increase kasi tinanggalan mo siya ng tubig. Okay? So yun lang yung tip ko for this type of table, or if may ganito kayong scenario. Pag nagsabi na stuck sa desert, ganyan, nag-diarrhea, or nagkaroon siya ng SIAD, ng syndrome of inappropriate diuresis, right? Just try as best as you can to look for the initiating event na pwede mong i-trace most of the events. Okay? So briefly, we have the tubules. Your proximal convoluted tubule is the workhorse. So ito yung reabsorption ng most of the substances, no? Kapag loop of Henle, your descending is permeable to water, while your ascending is permeable to solutes only. Sa loop of Henle, specifically your thick ascending, nandiyan a very important na sodium-potassium 2 chloride symporter. Okay? And then in the early distal tubule, then yung macula densa. In the late distal tubule, you have your principal and your intercalated cells. Pag principal cells, they secrete potassium. So Principi K. Si Principi K, principal cell secretes potassium. Your intercalated cells secretes hydrogen. So site naman to ng aldosterone. Okay, late distal tubule is the site of aldosterone because your collecting duct is the site of ADH naman. Okay. So I said earlier, most of the reabsorbed substances are PCT except for magnesium. Magnesium is mainly in the thick ascending limb of Henle. And then your calcium is both PCT and then LH. Your urea is PCT via simple diffusion, but facilitated naman siya kapag sa collecting duct. Okay? And then phosphate is mainly in the PCT. So what estimates GFR? Inulin or para-aminohippuric acid? It's your inulin, because your inulin is filtered but not secreted and not reabsorbed. So wag nyo lang siyang i-memorize, no? Try nyo siyang i-understand bakit ganon. Ito number 1 kasi yun yung filtered mo, right? Your inulin mo daw is filtered lang. So from the glomerulus to the tubules lang. So it will estimate the GFR kasi hindi na siya na-reabsorb and then hindi na siya na-secrete. That's why inulin estimates the GFR in this case. Your renal plasma flow naman is estimated by your PAH, your para-aminohippuric acid. So this one is not reabsorbed, but filtered and secreted. So it's estimated by the para-aminohippuric acid ang ating RPF, renal plasma flow. So ito sinabi ko earlier during the start, in our boards, we were asked to compute 2 substances ng clearance, no? So they gave all the details naman. So na-compute naman most students yung clearance ng item. So 2 items yung amin nun. So GFR, amount filtered, RPF, plasma flow, and then your RBF, your renal blood flow, is plasma plus hematocrit. And then your filtration fraction is your GFR divided by your RPF. Not divided by GFR over by your RPF, around 20%. Okay. So dito na ngayon papasok yung importance ng table na to. So in this table, you have to be familiar with the Starling forces, right? So the capillary hydrostatic pressure pushes fluid out. So filtration siya. Your interstitial oncotic pulls fluid out of the capillary, so filtration din siya. Your capillary oncotic pulls fluid in. Okay, so against filtration siya. Your interstitial hydrostatic pressure pushes fluid in to the capillaries, so against filtration siya. So that is very important, for example, in this table. So let's try to look at your efferent arteriole constriction. If you constrict the efferent arteriole, no, kinonstrict mo yung efferent arteriole, yung plasma flow mo hindi makakadaan, right? So that means your plasma flow will be decreased. So 1 point. What will happen to your GFR? Since nag-constrict yung efferent mo, yung plasma flow mo hindi nakakadaan, magba-backflow lang siya. Magba-backflow lang siya sa glomerulus mo or may ipon lang sila lahat sa glomerulus. So in the glomerulus, sobrang daming plasma. So madami kang pwedeng i-filter. So your GFR then will increase. Okay? Your GFR will increase. So what happens to the filtration fraction? By fraction ulit, no? Nag-increase yung numerator mo. So mainly, it will have an increase in filtration fraction. Okay? So yun yung concept in this type of topic, subtopic. Okay, so RBF, renal blood flow autoregulation, you have the myogenic mechanism. So very self-explanatory naman siya. But let's go on with the tubuloglomerular feedback. No, if you have an increase in arterial pressure, you will have increased GFR. So it will be detected by your macula densa. Your macula densa will increase secretion of your adenosine, right? Your adenosine outside the kidney is a vasodilator, but inside the kidney, it's a vasoconstrictor. So it will decrease the GFR back to normal. Kapag naman decreased arterial pressure, it will stimulate the renin aldosterone, the RAAS system. Okay, the RAAS, the renin angiotensin aldosterone system. Okay, sorry, and as well as secretion of nitric oxide. Okay, so angiotensin 2 will constrict the efferent and nitric oxide will dilate the afferent, increasing the GFR back to normal. So ito yung RAAS system natin, right? So yung renin secretion mo, it will be stimulated by 3 important factors like sympathetic nervous system, macula densa, and as well as your baroreceptors. Basically, renin will convert your angiotensinogen to angiotensin 1, and then angiotensin 1 to angiotensin 2 via the long capillary ACE. And then you have angiotensin 2. So very important is you have to be familiar with the 3 functions ng angiotensin 2. That's your potent systemic vasoconstrictor, efferent arteriole constrictor, and as well as increased secretion ng aldosterone. Your aldosterone will increase sodium and water reabsorption as well as potassium and hydrogen secretion. Okay? So, yeah. So fun fact, the renin in kidneys actually sometimes it's correctly pronounced daw as renin. So it's renin because renin, R-E-N-N-I-N, is an enzyme that degrades milk. Okay, so renin daw sa kidney. Okay, gastrointestinal physiology. So briefly lang. So you really have to be familiar with the hormones, no? Kasi most of the GI physiology questions are hormone related, no? So you just have to be familiar with all of this. Okay, so take note that CCK is from the I cells, and then your GIP is from the K cells. Okay, so don't be confused, ha? Si CCK hindi siya galing ng K cells. So pronounce it as CCK. CCK is galing ng I cells. Kasi everything else, gastrin G, secretin S, motilin M. CCK, baka mag-C kasi kayo, baka mag-K cells kayo eh. CCK is from the I cells. Okay, and then the K cells releases your GIP. Okay, so CCK, very favorite nila yan because it enhances bile secretion, plus it increases both endocrine and exocrine function ng pancreas, compared to secretin that only participates in the exocrine function via secreting your bicarbonate. And these are the other hormones, okay? So correlate your VIP in patho and IM, yung vipoma, right? considered as the pacemaker of the GIT, that is your interstitial cells of Cajal. Considered as the slow oscillating membrane, that is your slow waves, and determines the pattern of contraction, that is your slow waves as well. Okay, so you have here the slow waves versus the spike potentials. Yung spike potentials mo, yun yung true action potentials natin. Okay, so yung slow waves mo, ang mnemonic ko here before is yung slow waves, dahil mabagal sila, dahil mabagal sila, quote and quote, sila yung responsible for tonic contraction compared kay spike potential na mabilis gumalaw, na quote and quote mabilis gumalaw, sila yung for phasic contractions. Okay, yun lang yung mga tekniko para maalala ko sila, kasi I do understand na it's really overwhelming, no, yung buong board season, pero kaya niyan. Kaya natin yan. Okay? So these are the GI motility. So sinummarize ko lang dito sa slide na to kung ano yung makikita. So usually they don't ask the very detail of motility. They would usually ask saang organ mo makikita yung mass movement. Sino yung may house striations. Sino yung walang net forward movement. Ganon. Okay? So it's in this table and it's also in your handout. Pero naka-bullet siya sa handout nyo. So GI secretion, high bicarbonate by isotonic, that is your pancreatic secretion, versus your hypotonic, which is your saliva. Okay? So just take note that your salivary ductal cells kasi is impermeable to water. So in your salivary ductal cells, you reabsorb sodium chloride. So yung water mo, naiiwan mo lang sa loob. No? Hindi sila nakakadaan. So solutes lang yung tinatanggal mo. So in effect, nagiging hypotonic siya. Compared to your pancreatic ductal cells na permeable to water siya. So isotonic siya. So when asked, sinong mataas ang bicarbonate? Both. Sino yung isotonic and similar to plasma? It's your pancreatic secretion. And here, it's also in your handout. Okay, for hydrochloric acid secretion, take note of the three important substances. You have your histamine, your acetylcholine, as well as your gastrin. Okay, your histamine on H2, acetylcholine on M3, gastrin on CCKB receptors. Yang tatlong yan yung nagpa-participate for increased hydrochloric acid secretion. Okay, and then here, very important, your enterokinase from the brush border ng small intestine is the one responsible for activating your trypsinogen 2 trypsin. And then everything else will be because of trypsin. Okay. Whew. Okay, let's do this. So endocrine physiology. Okay, so syempre very basic is you have to must know yung concept ng HPA axis. Okay. So here are hypothalamic pituitary hormones. Hinighlight ko dito yung prolactin kasi si prolactin ang daming unique sa kanya. Okay? Prolactin is tonically inhibited by dopamine. Dopamine is also known as your prolactin inhibitory hormone, okay? Or your PIH, prolactin inhibiting hormone. So that means when your dopamine is decreased, your prolactin will increase. Tataas siya. Okay? What else? Your prolactin inhibits GnRH secretion. So kapag mataas ang prolactin mo, bababa naman ang GnRH. Wait. Kapag mataas ang prolactin, your GnRH secretion will be dik mo. So one important clinical correlate is kapag may primary hypothyroidism, patients with primary hypothyroidism can sometimes manifest with galactorrhea. That is because your TRH stimulates prolactin secretion. Okay? So if you have a patient in the clinic in the future with primary hypothyroidism, don't forget to check the breast area kasi baka may galactorrhea siya, signaling na meron siyang hyperprolactinemia due to TRH. Okay? Because of uncontrolled hypothyroidism. So, yan. So protein hormones, water soluble, lipid hormones are lipid soluble. So again, if you're gonna recall our first slide, water-soluble hormones, the protein hormones, ang receptor nila sa cell membrane. Bakit cell membrane lang? Kasi nga, ang water-soluble substances hindi nakakadaan all throughout the membrane. Kasi, di ba, hydrophobic yung tails ng ating cell membrane. So, there. Protein hormone activates existing substances, and then lipid hormones synthesizes new. Yung lipid hormones mo, as we mentioned earlier, they can traverse all throughout the cell membrane. Thus, they can reach the cytoplasm and nucleus. And since nasa nucleus na siya, so, depend pa ba siya sa mga existing? Hindi na, no? Gagawa lang siya ng sarili ng bagong enzymes. Okay? So, take note that in the hormones, you have to be familiar with the second messengers, like the cyclic AMP, IP3DAG, and this catalytic receptor mechanisms. When you say catalytic receptor mechanisms, ito yung mga enzymatic activity nila on the intracellular side ng ating cell membrane, like your guanylyl cyclase, receptor tyrosine kinase, and then your tyrosine kinase receptor, associated receptor. Okay? Yan. So you have to be familiar with this one. Okay? So ang clue ko lang dito is, I know this is an overwhelming slide, pero let me help you with a mnemonic that I made, no? So insulin's girlfriend, insulin's GF, insulin together with lahat ng may GF, gumagamit ng receptor tyrosine kinase. So EGF, PDGF, FGF, IGF-1, except for TGF beta, because ang PDGF beta gumagamit ng serine threonine kinase receptor. Next one, si Gabe's frenemies. Ito, far-fetched mnemonic, pero I hope it can help. Si Gabe uses cyclic GMP. So it has your ANP, BNP, and EDRF. And then we have your frenemies. Yung frenemies, yan lang yung concept ko nun, is it uses cyclic AMP. The frenemies uses cyclic AMP. So when I say frenemies kasi, FSH, LH, related sila. HCG and TSH, related sila. PTH and calcitonin, magkaaway sila, right? And then we have ACTH, MSH, related sila. And then V2, H2, pareho silang 2. Okay? So this is just my weird mnemonic, pero it helped me during the boards kasi they do ask kung anong ginagamit na signaling kapag ng gantong hormone. Okay? So recall nyo yung mga enzymes for thyroid function. Okay. Oh, okay, this one. I'd just like to point this out. Wolff-Chaikoff effect in the thyroid leads to hypothyroid. So Wolff-Chaikoff turn off ang thyroid hormone. Jod-Basedow phenomenon turns on the thyroid. Okay, so hyperthyroidism naman siya. And then adrenal gland, okay, actually yung GI kasi tsaka yung endo, very straightforward siya pagdating sa physio. So I am confident na you can all ace yung GI and endo part. And then everything else, you really have to put an extra effort, okay? So aldosterone, dito yung function niya, increased sodium rehab, increased potassium, and hydrogen secretion as well. So take note that your cortisol, it leads to neutrophilia, eosinopenia, and lymphopenia. Okay? Okay, so this one naman is your adrenal cortex, right? The mineralocorticoids, glucocorticoids, and yung iyong androgens. Okay. So I'd like to point out here briefly lang, no? So for this part, guys, you have to know yung enzymes kasi alpha hydroxy. So what happens is lahat ng subpool lang sa isang side, sa mineralocorticoid side lang, no? So that means kapag mayroon kang 17 alpha hydroxylase deficiency, walang pubic hair of glucose deficiency. Compared naman kapag 21 beta hydroxylase ang deficient mo in this part, okay? you will have ambiguous genitalia kasi nag-increase na yung substances mo sa DEA's pathway, and then you will have hypercortisolism as well. Vitamin D, both serum calcium, but vitamin D increases serum phosphate. Your PTH decreases phosphate. Kaya siya PTH, no? Phosphate thrashing hormone. So, recall lang, external genitalia for male is dihydrotestosterone. Internal genitalia for male is testosterone. And then the enzyme for that is your 5-alpha reductase. Okay, so this is mainly for repro. Then this slide is for your anatomy. So you have to be familiar with the with the homologous structure. Kasi they ask this in the boards, okay? Okay. Doc Nins, do I still have time or?
Yes, Doc.
Okay. So briefly lang itong hematology and special environment physiology. This is actually the last part, okay? Okay, so take note na yolk sac sa simula, and then liver, spleen, and then bone marrow. But I would like you to focus more on this part, okay? The innate versus adaptive immune system. Innate immunity, guys, andyan na siya sa katawan mo, no? Ready to fight na siya. So mabilis ang action niya, first line siya. However, since nandyan na siya, kahit ready siya mag-fight, hindi niya kaya totally i-fight yung agent. No? That's why you have the adaptive immunity. The adaptive immunity is capable of producing memory cells and capable of adapting para sa next time magkaroon ka ng exposure, mas potent na yung pagpapatay sa organism or sa substance na nagtitrigger ng immune system mo. Okay? Now, between the adaptive system, you have two. You have the humoral and you have the cell-mediated. Okay? So humoral, just tandaan nyo, humoral, B cells, antibodies yan. Cell-mediated, T cells, type 4 hypersensitivity yan. Okay? So usually common questions dito is saan nag-originate si B and T cells? Both sa marrow. But pag ang tinanong is saan cells, si T cells sa thymus, B cells sa bone marrow. So briefly lang then, this is your antibody. This is your FAB region, your FAB region, your fragment antigen binding. Diyan siya nagbabind. And then your FC region is for your complement and your macrophage binding. So FC, complement and macrophage. Your variable portion, itong letter V, your variable portion is for specificity na antigen, while yung iyong constant rather is for the antibodies itself. So this is more detailedly discussed in biochem, I believe. Okay. So for this one, if you want to take down notes for this one, okay, so most abundant immunoglobulin. What is the most abundant immunoglobulin? It's IgG. Most produced overall, it's IgA. Crosses the placenta, it's IgG. Crosses epithelial cells, it's IgA. Okay, so primary response, mauuna, IgM. Secondary response, IgG. Allergies, IgE. Largest, mauuna at malaki, it's IgM. Smallest is IgG. Okay. Okay, for this one, I'll discuss this in the Quizmaster later. Okay, itong mga complement kasi ando naman siya. Okay, and then as well as this one, the cytokines as well. So first step of hemostasis is your vasoconstriction. Favorite question for some reason is the first step of hemostasis. It's vasoconstriction. And the effect of primary hemostasis is platelet plug. And the effect of secondary hemostasis is blood coagulation. Okay, so important, GP1B, sa baba guys, GP1B is for adhesion. 2B3A is for aggregation. So around this time, I'm just pointing out yung mga important details, ha? Kasi ito yung mga nooks and crannies as Dr. Broly taught us, no? Ito yung mga nooks and crannies na usually hindi natin napapansin pero tinatanong nila. Okay? 1B, adhesion. 2B3A is aggregation. And then we have the clotting factors. So this is my mnemonic when I was studying. So my medtech friends taught me this. So you have your own mnemonic for this one, pero this is what I use, no? So these are the blood coagulation factors. Okay, so wala na tayong extra time. But I'll discuss the other parts sa Quizmaster naman, okay? Yeah, so that's the end of the summary physiology for this session. So I hope I was able to point out ano yung important and the high yields. As you can see, pagdating ng endo and GI, we've fast track because those two systems are very straightforward. No, if you know it, you know it. If you don't know it, use your testmanship. Okay? Kasi yung other part, yung first part, doon talaga sila nagtatanong ng mga scenario and doon sila nagpapaikot-ikot ng questions. Okay? So this is just my study desk when I was studying. So here. Yeah. So where you currently are is it where you're going to be forever. No, hindi kayo forever mag-aaral. Eventually, may tatapos din kayo and then eventually makakapag trabaho na kayo. Okay?